Ma'am, may I continue?
Yeah, continue.
Sakshi, what is this importance of diabetes? And you are telling patient is
Uh,
taking some oral hypoglycemic agents. So what is the importance of knowing this oral hypoglycemic agent?
so actually, whatever diabetes is itself a risk factor for developing like atherosclerosis, it will be aggravating the existing disease, and if it is uncontrolled, then
Any specific specific with the metformin?
Any complication of metformin which causes pain, or Sakshi?
it, it's one of the side effects is lactic acidosis.
So your side
Yes.
effect is also lactic acidosis, and you are going to do angiography, no? Suppose if
Mm.
you are planning for any re-intervention this patient, if you are going to do angiography, metformin and ACE inhibitor, you should be starting at least 48 hours before the procedure, and 48 hours post procedure you should stop this anti diabetic agents, because it will worsen your AKI and kidney injuries because of your contrast induced nephropathy. So you should stop your metformin and your ACE inhibitors predominantly. And what is the goal?
Actually, you have to get the EGFR done. Based on EGFR, I think you have to decide.
So Sakshi, how much will be your glycemic control of HbA1c level if you are advising the patient for diabetic patient? If you want to advise this patient, your HbA1c level should be less than.
What is a normal
Seven.
HbA1?
Normally, it should be less than 6, I mean, for a non-diabetic patient.
For diabetic patient, no, your HbA1c level should be less than 7.1. And
7.
suppose your patient is hypertensive, what advice will you give to this patient? How much of your blood pressure should be under level?
140 by 90.
So your blood pressure should be by 140 by 90.
Yes.
Okay. So your past history is almost your under to amputation is fine. Next.
Sakshi, you have not mentioned impotence and all those things, na, about Leriche syndrome in the history.
Uh, yes, ma'am.
Yeah, you have to mention.
Yes, ma'am.
What is Leriche syndrome?
Ma'am, when the occlusion is at the level of like aortoiliac region, so there will be absent femoral pulsations, impotence, and there will be
What?
pain in the gluteal and the thigh region. This is
Yes.
Lerick syndrome.
Yes.
Sakshi, why this claudication, why this atherosclerosis patient, they'll be having predominant pain at calf region only.
So the most common site of occlusion is the femoropopliteal junction. So the pain
Is
would be
it
in calf.
is it femoropopliteal junction or any other vessel?
Femoropopliteal.
So they will get
If yeah.
so they will get more pain because superficial femoral artery is most commonly involved in the atherosclerosis.
Superficial femoral artery is most commonly involved.
Okay.
Not your femoropopliteal junction, superficial femoral artery is involved most commonly. So that's why they'll be having predominant pain at the calf.
Okay.
Suppose this patient is diabetic patient, not only not atherosclerosis. So which vessels is predominantly involved in diabetic patients? Any idea?
How do you describe angiopathy of diabetes? Any idea? I think it solves the answer.
Tibial arteries would be involved.
So your predominant, your lower limb crural vessels such as anterior tibial artery, posterior tibial arteries are predominant involved. So this diabetes, no, it will affect only your small vessels predominantly.
Digits, mostly digits and the lower limb.
Okay.
Yeah.
Go to your next slide.
Yes, sir.
How does smoking affect this patient? Sakshi?
Ma'am, smoking, it contains nicotine, so it would be doing vasoconstriction and it also would release carbon monoxide. So it would be displacing the oxygen from hemoglobin as well.
Why does it affect thromboangiitis obliterans? Is it the nicotine which is a risk factor, or is it any other thing?
I
So,
don't
so
think
a
it's
50-year-old,
nicotine.
50-year smoker came. The patient is having smoking history
Mm.
in this patient, and it also, but also in thromboangiitis obliterans. What is a different thing in How does the mechanism different in thromboangiitis obliterans compared to this patient? Is it nicotine which is more toxic, or is it something? It's a tobacco protein which is more dangerous. Huh? This tobacco protein causes antigen antibody reaction, because of which the inflammation happens.
Mm.
So the tobacco protein is more dangerous in thromboangiitis obliterans, whereas the nicotine and carbon monoxide is more in atherosclerosis.
Okay, ma'am.
So Sakshi, basically, no, you are going to do your give your examination also. So when you are writing no smoking and all, so you have to mention
Mm.
what is the smoking index, okay? So
Okay.
what is
Okay,
this,
sir.
Back
Okay, sir.
years.
what is this pack years of smoking?
Okay, sir.
So what does basically this smoking, which compound it will contain, which
So
gas
carbon
predominantly it will
monoxide.
contain?
Carbon monoxide.
So your carbon monoxide is very much dangerous. So
Yes, sir.
so basically when you are giving your smoking, no, it will lead to your severe arterial spasm, vasospasm will happen. So it will decrease your blood supply to your peripheries. And also smoking will affect your collagen formation, your neointimal synthesis. Your intimal synthesis, it will injure the basically your collagen synthesis and intimal hyperplasia will happen.
Yes, sir.
Okay, so smoking is also your delays your wound healing. Whatever patient will have minor trauma, no, they will sustain wound, and so smoking leads to delay in wound healing. So next time mention in the pack years and number of and smoking index also.
Yes, sir.
Sleep disturb due to pain. Okay, fine. Go to next slide.
Yes, sir.
So basically, no, your atherosclerosis also it runs in the family. So what is this metabolic syndrome? Do you know?
Sir, familial hypercholesterolemia.
So your familiar hypercholesterolemia. So patient will be having which kind of diabetes? Your type 2 diabetes will happen in these patients predominantly.
Yes, sir.
So patient will be having multiple risk factor for coronary vascular disease and everything.
Yes, sir.
ठीक है, has hypertension, asthma. Next.
Yes, sir.
So your summary is fine. Just mention presenting with the rest pain.
Okay.
You have mentioned the pain, no? You just mention rest pain. And when you are starting your HOPR also, no, HOPR you can mention patient is known case of diabetic and smoker. How you are going to start with your
Oh.
CLD patient alcoholics, no? So that you can start with your
Mhm.
HOPA in this aspect as a patient is a known case of diabetes and also known case of smoker. So that examiner
Okay,
they
sir.
will be having one idea that you are going to do with some peripheral vascular disease case.
Yes, sir.
Okay.
Sir,
So
may I move to the next slide?
yeah. So you are what will be a probable diagnosis? What will be etiology in this patient this
Pe-
age?
Atherosclerosis mostly.
Okay, one is your atherosclerosis because of your rest pain also peripheral vascular disease. Any other differential diagnosis? Can it be case of diabetic foot?
Simple diabetic foot.
Mm, no, sir.
Why not? Then diabetes also, you are only telling the crural vessels gets involved, the tibial vessels involved, and there is a diabetic microangiopathy, which might lead to the ulcer on the great toe. So why not? It can be diabetic foot, simple diabetic foot.
Ma'am, pay, The pain component, due to the pain component.
Only pain and only pain, so that's why you are segregating it.
Ma'am, diabetic foot, there should be neuropathy, ischemia, infection as well.
Yeah, yeah. See, whenever diabetic patient they are having infection, no, they will be also having continuous rest pain. Initially, they'll be having peripheral neuropathy, only tingling and numbness sensation will be there. Once their ulcer is get infected, once the patient is having wet gangrene changes, once the patient is having any cellulitis, underlying osteomyelitis, in that aspect, patient will be having continuous pain because of your infected etiology. So that also mimics your peripheral vascular disease. So you need clinical examination to rule out it, whether you are dealing with peripheral vascular disease or it is a case of diabetic foot with some other complication of it.
Okay.
Did you get my point, Sakshi?
Yes, sir.
So it could be peripheral vascular disease, and also it could be case of diabetic foot with some other complication associated with it.
Sir.
Let's go to the
Go to your examination.
examination. Sakshi.
General examination. The patient is conscious and cooperative. Weight is 75 kg and height is 168 centimeters. Pulse rate is 80 beats per minute, palpated on right radial artery. Blood pressure is 110 by 70 mm of Hg, taken in right arm in sitting position. Mild pallor is present. Icterus cyanosis, clubbing, and lymphadenopathy is absent. Local examination, inspection. The patient
Sakshi,
was examined in supine.
your general physical examination. Go to your general physical examination.
Sakshi, what is the
Sir,
BMI of the patient? Why BMI is important in this case?
because obesity is a risk factor for this.
The BMI is important. And what all things you have not mentioned in pulse?
Rate, rhythm, volume,
Why? This is a case of
character.
PVD, na? So everything is important, na?
Yes, ma'am.
Yeah, everything is important. Where do you see the character of pulse, Sakshi?
Ma'am, I palpated it on right radial artery.
Character. What are the different
Carotid.
things? What are the different things in pulse you will see?
Ma'am, rate, rhythm, volume, character, radiofemoral delay.
Radio radial delay.
Yes, ma'am, radial delay.
So Sakshi, what is the pulse? Define pulse.
The pulse is the pressure waveform generated due to the changes occurring in the left atrium,
Atrium or
like due
ventricle?
to the ventricular contraction. A ventricle generated by ventricular contraction, and it is transmitted through the arterial system, and it is palpated against bony prominence.
So whether it is due to whether pulse is felt due to partial filled aorta or completely filled aorta. So basically your pulse is your pressure distension wave produced by your contraction of left ventricle against your partially filled aorta, which is transmitted to peripheries and which is felt at the bony prominence.
Yes.
So that is the definition of your pulse. So
In
basically,
carotid, what?
you have to mention all the findings of your pulse in this aspect, and you have specifically mentioned right radial artery. That is fine, and you have to tell, sir, other examination of pulses. I will tell in the local examination.
Okay, sir.
Other pulses, matlab, the peripheral pulses will be mentioned in as a part of local examination.
Okay, sir.
Where do you see volume and character, Sakshi?
Carotid artery.
Yeah, that is specific. You have to tell. Pallor is present. Icterus cyanosis, clumping, lymphadenopathy. Okay.
So along with this, no, Sakshi, you have to see, basically you are dealing with atherosclerosis, no? If you are taking any case in the
Yes,
medicine
sir.
also, no, CVS case, see, suppose if you are taking any case
Mm.
of CVS in medicine, no, you have to mention whether there are any signs of peripheral atherosclerosis. So what are the signs of atherosclerosis, peripheral atherosclerosis?
Sir, there would be a loss of the hair. Again, the skin would
No, no,
appear
no.
shiny.
No, 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 no.
Head to toe signs of atherosclerosis or hypercholesterolemia.
Sir,
Like
Any
the
skin
limbs.
changes, any periorbital changes.
like if you are taking any case of CLD,
Uh,
you will be mentioning so signs of hepatic cell failure. If you're taking severe signs of cardiac
yes,
cell
sir.
failure, or if you're taking any CNS case, you will be
Yes,
mentioning neurocutaneous marker. So if you're taking any case of peripheral vascular disease, head to toe, you have to mention there are any signs of hypercholesterolemia or atherosclerosis. So that is important.
yes, sir. Yes, sir.
So you will be having your xanthilesma around the eyes, xanthomas,
Arcus.
arcus senilis. Okay.
Yes, sir.
So those are your signs of peripheral signs of atherosclerosis.
Yes, sir.
So icterus cyanosis, clubbing, lymphadenopathy, absent is fine. Okay, next slide.
Yes, sir. Inspection. The patient was examined in supine position and was exposed from ASIS till toes. Attitude. Both the legs were hanging by the side of bed. Fifth toe of right foot was amputated. Loss of hair over the toes and dorsum of feet. Nails are brittle. Wound present on right heel. Great toe discoloration was observed and ulcer present over great toe.
Any muzzle wasting is there? Sakshi, is there any muzzle wasting or any sort of that thing, any thinned out limb sort of thing?
Yes, ma'am.
Yeah, you have to mention muzzle wasting also in inspection. Fifth toe,
Yes.
amputated, loss of.
Uh, Sakshi, first no.
How is ulcer? You have not mentioned Sakshi ulcer. In local examination, you have to tell what kind of ulcer is it, na?
And more than that, no, Sakshi,
Yes, ma'am.
first no, this is your right limb pathology. No, first you have to tell about left limb. Left limb examination is normal. Then compare your left limb with the affected limb. And that you have mentioned wound on right heel, whether it is wound or whether it is ulcer, you have to mention all the examination of wound or examination of ulcer properly.
Okay, sir.
I think
So this no loss of hair over toes and dorsum of foot, you can mention, sir, there are signs of peripheral vascular disease such as loss of subcutaneous fat, loss of hair, brittleness of nail, okay, wasting of the muscle. So you can mention in the one line. Great toe discoloration was observed. So what is the discoloration?
Sir, it was pale. I mean,
Only grade 2 was pale.
more pale as compared to the.
See, basically, if there is black discoloration, you can observe it, but the more pale compared to surrounding area, it is less likely. So if there is any black discoloration or any skin discoloration, you have to mention rather than it is pale appearance. So suppose you are not mentioned this ulcer finding. So which type of ulcer will you get this in the peripheral vascular disease or peripheral arterial disease?
and what is the position of the ulcer specific?
Transplantation.
What? What? Come again?
Present over grade 2 and it had punched.
Punched out edges on the grade toe.
See, first you have to mention
Yes,
site.
ma'am.
Next one is your size. Next is your shape of ulcer. Okay. Next one is your edges. Next one is your how the floor is looking, and then the surrounding area. And first you have started only with your surrounding area first. First describe all the ulcer findings. Then go to your surrounding area examination finding. In that surrounding area examination finding, mention about the patient is having loss of hair, toes, and all. So this suggests you of signs of peripheral arterial disease.
Okay, sir.
Go to the next slide, Sakshi.
Yes, sir. Palpation. The inspectory findings were confirmed on palpation. The right lower limb extremities are cold than the
Sakshi,
left. Tenderness is present.
so before going to your palpation, no, there are some other examination in the inspection also. What was your Burgess angle?
Okay. Sir, when we ask the patient to
No,
elevate his limb up to a certain angle and keep
in
for
your patient, what was Burgess angle?
Is it relevant?
Is it relevant in this patient?
Where do you do the test, Burgess
yes,
angle
ma'am,
test?
it is. Ma'am, we ask the patient to elevate the limb to a certain
No, no, no. What
angle
I'm
No, no,
asking
and
you,
he should be in supine position. And then we
no, what is the prerequisites? Your patient is having rest pain, right? Is there any significance of doing that test?
ma'am, when the angle, Burgess angle would be less than
no,
20
no.
degree, that would be suggestive of
Sakshi,
CLC.
if your patient is having intermittent claudication, then only you have to do your Burgess angle test. If your patient is having rest pain means your limb is only in the supine position. So automatically it means Burgess angle less than 30 degree only. So specifically no need to mention separate Burgess angle in this patient.
Okay,
If your patient would have had intermittent claudication in the history, then the Burgess angle test is relevant.
okay, ma'am.
Yeah.
Okay,
So
go
let's
with
continue with
palpation.
the. No, no, no. Continue with the palpation.
Inspectory findings were confirmed on palpation. The right lower limb extremities are cold than left lower limb. Tenderness is present over great toe and non-healing wound of 2 by 1 by 1 centimeter over the right toe. It is solitary, oval-shaped ulcer, punched out margins, and surrounding is pale. There is a non-healing wound over right heel, which is 3 by 2 by 1 centimeter, and the capillary refilling time is 15 seconds.
See, remember Sakshi one thing now. So when you are taking ulcer examination, so whichever ulcer is bigger in the size, you have to describe that ulcer properly. And your non-healing ulcer over the right heel is 3 into 2 into 1 centimeter, and the other ulcer is 2 into 1 into 1 centimeter. So in remember in examination also, whichever ulcer size is bigger in size, no, you have to describe that ulcer properly. And apart from that, you have to mention, sir, there are multiple small ulcers, or there are one more small ulcer is present in that aspect with size this. You can mention that ulcer. If you miss that ulcer is also like you have to just mention that ulcer in the single line. But whichever ulcer is bigger side, no, explain that ulcer properly. And this is not non-healing wound. This would be a case of non-healing case of chronic ulcer or callosity.
Chronic ulcer.
So you have to mention this ulcer
Okay,
properly. In the examination of UG
yes,
examination,
sir.
no, if you miss this,
Sakshi, how are you tagging it a non-healing ulcer? You will tell it a non-healing ulcer based upon what you see, na. That is the final diagnosis, but you have not at all mentioned how the ulcer is, na.
see UG examination, no, all the
Yes,
UG
ma'am.
examination, all the PG examination, it revolves around only two things in the surgery. One is ulcer, another thing is your swelling, either breast, thyroid, or any lump in the abdomen. Those are all swellings only. So describe properly in the swellings and describe properly ulcer.
Okay,
First to examination of ulcer, then go to the surroundings.
sir.
So how will you do this
Non-healing ulcer.
capillary refilling time?
Sir, your voice was not audible.
How do you see the capillary CRT, capillary refill time?
Ma'am, I checked it over the pulp of the dose. I first enhanced it for almost 10 seconds, and then it took almost 15 seconds for it to become pink again.
How much? Come again?
Ma'am, your voice is not audible.
No, no, no. Once again, explain how do you do capillary refill time? How do I elicit capillary refill time?
Ma'am, I pressed over the tip of the like pulp of the toe for 10 seconds, and then I released the pressure, and then it took almost 15 seconds for it to turn pink again. I mean,
So tell me, how will you do the Burgess angle test? What all the findings you will see in the Burgess angle test?
so first of all, I would ask the patient to lie on his back, and then I will ask him to raise his legs and keep his knees straight, and then for after some time the color change would be observed. I mean, it would turn pale.
No, no.
You only see color changes, or patient will tell something, or you will see some other things also.
What is the first thing patient? What is the patient? Matlab, first thing is a color change, or first thing what? Don't the patient have pain, or don't patient have some discomfort?
Yes, ma'am.
So your patient will be in supine position with the straight leg at normal at knee joint. You will ask the patient to lift his leg. Suppose if your patient is having starting developing pain at the particular position, you will note that position, and also you will be seeing the changes, any discoloration of or any paleness of the your skin, and also you will be seeing your gutterness or emptying of the veins. Suppose, and on the basis of that you will be seeing 30 degrees, 60 degree, 90 degree and all. Suppose after doing 30 degree also, if your patient is a
Okay.
case of peripheral vascular disease, and on doing 30 degree also your patient is not
Mhm.
having any signs of this, then you will do some other maneuvers. What
Mhm.
maneuvers you will do? You will hold the leg at 30-degree position, and you will do dorsiflexion and plantar flexion at ankle
Mhm.
joint multiple times, so that you have to just exaggerate the things.
Yes, sir.
You're pumping the blood more.
So this is how we'll do Burgess angle test. So how will you do, Sakshi, capillary filling time? So you have told this is capillary refilling time, that is your palpatory finding. How will you do capillary filling time?
Mhm. Sir, after elevating the legs, I'll ask the patient to sit up and hang his legs.
So ask the patient to sit up and hang his leg down. So the leg which was pale on rising, and it will become normal color on the hanging down position. So you will be measuring the time duration at which time it will become normal position. So how will you see the venous filling time?
Yes. Um, Sir, I'll use both my index
No,
fingers
no, that
and
is venous refilling time. That is Harvey sign. That is palpation. Venous filling time.
Venous filling time.
I'm only asking venous filling time.
sir, sir, patient, his limb would be elevated and then it is like flat.
So your patient leg which was elevated before, and there was guttering of vein, and you'll be asking the patient to keep the bed flat on your bed. So you will be
Normal
measuring
position.
the times of appearance of refilling of the veins. So you'll be measuring the time, that is called as venous filling time. So in inspection specifically you have to mention these all the findings in during only intermittent claudication. These tests are not important in your rest pain.
Chest pain. Okay.
And because in rest pain your patient is having already pain, and by doing all these tests you are giving more pain to the patient. So your dictum of medicine, you should never harm to the patient. Okay, so never do this
Yes,
kind of examination if your patient is having rest pain.
yes, sir.
So how will you do venous refilling time? Then you have to mention this harvest sign of harvest test.
Yes,
Okay, go to next finding.
yes, sir.
So Sakshi, just tell about all these pulsations. Where will you feel specifically? Dorsal spinatus, anterior, and other vessels.
Tell the bony on which bone you will palpate and any tendon relation to tendon.
Surface landmark for these.
Yes, ma'am. The dorsalis pedis, it is palpated on the dorsum of foot lateral to extensor hallucis longus against the navicular bone. The
In,
anterior
in
tibial
which
artery, it is palpated
in which way of space?
over. Sorry, sir, your
In which way of space?
first,
So you will be feeling dorsal pedis in your first web space.
first web space.
Okay, then
Sir, anterior tibial artery is felt in the middle, in between the two malleoli.
so you'll ask the patient to do dorsiflexion or plantar flexion. Hello.
Sakshi, are we
Sir, your
audible?
voice is not audible.
Now, are we audible?
Hello?
Are we audible?
Yes, ma'am.
Yeah, you will ask, you will
Yes,
do
ma'am.
anterior tibial palpation in dorsiflexion or in plantar flexion? Anyone about the palpation of anterior tibial artery? Sakshi, are you there?
Ma'am, dorsiflexion.
So you have to do dorsiflexion and you have to feel against the lateral to the extensor hallucis longus tendon in between the two malleoli against your lower end of.
Tibia.
So against you have to feel against your lower end of tibia.
Calculate.
So where will you do this examination of posterior tibial artery?
The posterior tibial artery is palpated behind the medial malleolus, midway between the medial malleolus and tendoacetus.
Okay, fine. Next, popliteal artery.
So for palpating the popliteal artery, patient should be in supine position. We would ask him to flex his knees. The thumbs would be placed on the
So
tibial
how much
tuberosity,
how much
and with the help
how
of the
much will you
fingers, we would be
ask the
it.
patient to flex the knee?
So 40 degrees.
So you have to ask the patient to do flexion at knee joint at 40 degree. Then
Then we would be palpating over the lower part of like the popliteal fossa with our fingers against the medial and lateral bones.
Fingers against the medial.
With the fingers, we would be placing it in the popliteal fossa and we would be palpating it against the tibial condyles.
ठीक है, then next.
What is the other method? What are the three methods? No. What is the second method?
Ma'am, patient should be in prone position,
Okay.
uh, and we have to flex his knee
Yes.
parallelly.
Where do you in flux in prone position? On which bone you will palpate? Femur. Sakshi, actually, you're not audible.
Hello.
Yeah, yeah.
Uh,
On which
yes,
bone you will
ma'am. We
palpate?
would be passively posterior face.
So where will you feel this femoral artery?
Sir, it is palpated uh, below the inguinal ligament at the level of deep inguinal ring against the neck of femur.
No, no. Basically, this femoral artery, no, you will palpate
Landmark, landmark.
landmark.
Mid inguinal point, midpoint of
Mid-inguinal
inguinal.
point. Mid-inguinal point.
So you will feel this femoral artery just below the inguinal ligament at the mid inguinal point against the head of the femur. So third method
It's
of
not neck of the femur, it's the head of the femur.
head of the femur. So third method of popliteal artery
Yes, ma'am.
doing your Fuchs test or cross leg
Yes,
test.
sir.
What is cross leg test?
Just, ma'am, we ask the patient to sit. His legs should be crossed over one another. We would be diverting the patient's attention by asking him some questions, and the cross leg, if the oscillatory movements are seen, so that is Fuchs positive, means the popliteal artery is patent.
Yes, yes, yes. And what are the other pulses you will palpable? You have palpated any other pulses?
Radial artery,
Yeah.
carotid artery.
Yeah. Carotid, superficial, temporal. You have to all other pulses are normal. Such sort of thing.
So where will you do this carotid pulsations? Where will you feel the carotid pulsations, Sakshi?
So it is felt against the medial border of sternocleidomastoid at the upper thyroid cartilage.
What on which bony prominence?
Oh,
It is Sakshi, these are very important things, sir. Because if there is no bony prominence, you can't palpate a pulse. Any pulse you are palpating, it is because there is a
transverse
posterior. Huh. What?
from transverse process of cervical vertebra.
Which
Which
cervical
cervical
vertebra?
vertebra?
C4.
So you are going to feel against the transfer process of your C6 vertebra, that is also called as Chesagian tubercle. See, this examination of peripheral vascular disease, no, it is incomplete without doing proper examination of your pulses,
Pulse.
proper examination of your ulcer, and proper examination of all the peripheral pulses. Because is this UG level also, PG level also, this they will ask this much basic, because this is the important. You can't miss this.
Yes.
Go to next slide.
Yes, sir.
Sakshi, you have not mentioned about the movements of the limb. How are the movements at the ankle joint? How are the movements at different joints? You have not mentioned. And the second thing, you have not mentioned about any inguinal lymphadenopathy. Because the patient is having ulcer, na, at least popliteal nodes, any inguinal nodes, those specific lymphadenopathy you have mentioned. You have to mention. Because you have mentioned generalized lymphadenopathy as a part of your general examination, but you have not mentioned any local lymph nodes here. Yes.
And also examination of musculoskeletal system is very much important. Examination of your neurovascular structure includes you have to check the examination of whether patient is having any kind of neuropathy, what is the sensation level of this patient, whether there is any diffuse muscle atrophy, and how the reflexes are there in the both the limbs. Because your patient
Yes,
is
reflexes are very motor
diabetic patient, you are telling, no, you have to see how the patient's reflexes are there, how the joint movement is there, what is the status of
sensations are.
muscle. So peripheral vascular disease, you have to do all the examination of musculoskeletal examination also.
Yes, sir.
And as Madam told, examination of inguinal lymphadenopathy is also very much important, because non-healing wound over healed since 3 weeks and all, no. So you have to see any patient is having inguinal lymphadenopathy.
Yes, sir.
So you have to do in a local examination, no, just divide this and local examination and also focal examination.
Yes, sir.
Auscultation, ठीक है, no bruise heard on arteries of lower limbs and all fine. Next.
Sakshi, you have told the dorsalis pedis is not palpable. Is there any thickening of any sort of thing at dorsalis pedis, or it's not palpable only?
Ma'am, it was not palpable when I
Okay.
compared it with the opposite
And
one.
Sakshi, when you are
Okay.
doing this examination of lower limb vessels, no, you have to mention upper limb vessels also: radial artery, ulnar artery, brachial artery,
Brachial.
carotid artery, subclavian artery, all the superficial temporal artery, all the vessel status is also very much important, because your atherosclerosis is your multisystemic
Okay, sir.
disorders. It involves you are from head to toe. So never miss all the systemic examination also.
Yes, sir.
Your auscultation is done next.
Systemic examination, CNS, the patient was conscious and oriented. CVS, S1, S2 heard no murmur. RS, air entry was equal on both sides, and per abdomen, it was soft and non-tender.
Okay. Next.
Diagnosis, probable diagnosis, peripheral arterial disease of right lower limb with ulcer present, uncontrolled diabetes, probably due to atherosclerosis.
And palpations also, no, Sakshi, you have to mention whether there is any localized temperature, whether there is any tenderness
She have,
present.
men- she have mentioned. She have mentioned.
Okay,
Yes, sir,
so
the limb was cold as compared to the
okay, fine. So what is this? What is the definition of gangrene, Sakshi?
sir, it is the uh, tissue necrosis with superimposed
Specific.
decomposition
Any
due
specific
to
definition?
bacterial infection.
No, no. What is the definition of gangrene? Macroscopic death of tissue with superadded putrefaction.
Due to
Because ulcer is due to microscopic death. Your gangrene is your macroscopic death of tissue with superadded putrefaction. That is your dry gangrene. If it is superadded with desiccation or infection, that is your wet gangrene.
bed gangrene.
These definitions are no very much important in examination. What is ulcer? What is wound? What is gangrene? What are the types of gangrene? All. So peripheral arterial disease of right lower limb with you have to mention whether ulcer is healing ulcer or non-healing ulcer, or whether it is a callus. So basically there is healing ulcer, there is a spreading ulcer, there is a callus. So you have to mention the status of ulcer present with uncontrolled diabetes. And by doing this examination, how did you come to know whether it is diabetes is controlled or uncontrolled?
If the patient was not compliant to his medications, he had left to take it. So,
That you should not
You
mention
know,
here. No? That is a part of lab investigations. No?
so you have to
After
mention
investigation.
non-compliant to treatment, not controlled or uncontrolled.
okay, sir.
Why it is not acute limb ischemia, Sakshi?
Ma'am, acute limb ischemia, it will be the pain would be sudden.
So I tell this patient is of acute limb ischemia, and in meantime the patient have formed ulcer. Why it's not? Is there any specific definition timeline for to call it acute limb ischemia?
Ma'am, less than
2 weeks. 2 weeks.
2 weeks.
Yeah.
And also in acute limb ischemia, it won't be like patient will be less than duration is also less than 2 weeks, and severe pain will be there. Some P's are there no in acute limb ischemia.
Okay, sir.
What are or
Yes,
how
sir.
do you
6 days.
6 piece?
Ma'am, pain, pallor, pulselessness, poikilothermia, paresthesia, and paralysis.
So these P's are also important in acute limb ischemia.
Sakshi, can it be an
Yes, sir.
embolic phenomenon of a thrombus?
Ma'am, mostly it will be a thrombus.
No, no. It's an atherosclerosis. You are right. You are 100% right. It's an atherosclerosis. Can it be a floating thrombus, and from that floating thrombus embolism might have happened to great toe, and this great toe had got so little toe before it was the patient was amputated. Now, can it be embolic phenomenon of a thrombus? Did you understand what I'm
And
asking?
yes, ma'am. But ma'am, embolic phenomena, it would be more of a sudden phenomena. Uh,
Yeah, the patient of the fifth toe amputation is because of gangrene only, no?
yes, ma'am.
Yeah, why can't it be embolic phenomenon of the thrombus? It can be a floating thrombus or it can be a ulcerated thrombus. Why can't it be? Generally, in this embolic phenomena, the very small digital arteries won't get affected. So it is unlikely. Yeah. Okay. Then how do you proceed with this case?
First, we would be doing investigations and
What all investigations you will do?
for CBC, then blood glucose, HbA1c levels. Then we can proceed with a duplex scan.
What more?
Then, if
Blood
we are
investigations
planning
बस उतना
some,
ही बस 3 investigations बस CBC कर CBC बस BSL और HbA1c nothing more.
ma'am, a lipid level, like lipid profile, cholesterol,
Lipid profile,
triglycerides,
yes, yes,
it's even serum electrolytes and KFT.
yeah,
Ma'am, for the heart, like ECG and echo.
yes. Why you are doing ECG and echo? You want to rule out embolism, any sort of atrial thing, some sort of thing, na? Whether the atrium
Cardiac
is
causes,
flowing.
like,
Yeah,
yes,
you are ruling the cardiac causes, and then how do you proceed?
And also you have to do fundoscopy. You have to do UAG abdominal pelvis. You have to do examination of same
But
limb.
in this patient, it is not likely USG replacement because there are no any clinical symptoms pertaining to sort of thing. Or else, if the patient is telling any decreased urine output, you have to do renal artery Doppler. But in this patient, at the acute episode, maybe not. Maybe later, stabilizing the patient once.
And also you have to do both the lower limbs duplex, not only with a single limb.
Yeah.
yes, yes.
So what is this
What
duplex?
is
Ma'am, duplex scan is Doppler along with B mode USG.
what is this B mode USG? What is duplex? What is B mode USG?
Ma'am, it is, ma'am, in Doppler, like, we send a signal, so with sound waves, by using the probe, and B mode USG, it tells us about the flow in the artery, whether it is triphasic, biphasic, or monophasic.
And it tells the condition of the vessel wall also, no? It tells the condition of the
Yes,
vessel wall, the
ma'am.
thickening of the vessel wall. What is the normal flow of the artery?
Triphasic.
Why does the three phases of why the three waves, three waveforms? What does this signify?
Ma'am, three phases are systolic, diastolic, and then there's a elastic recoil.
Yeah.
So, Sakshi, see, basically this duplex, no, it includes both your Doppler and B mode imaging. So this Doppler, no, it will provide your physiological, like how the blood is flowing, okay? And this B mode imaging, no, it will predominantly give your anatomic status of your vessel. So the duplex, it includes both your physiological and also your anatomical, how the blood is flowing, how the character of vessel, how much your patient is having stenosis and all. It will explain. So what is this
Sakshi,
Doppler shift?
how do you see? How do you see the changes in the Doppler? Any colors? How does this
Um,
Doppler?
red and red and blue color.
If the blood is flowing towards the Doppler probe, then what is the color?
So reverse flow, it is red color, I guess.
Reve is red towards us. Sakshi, is there changes of any changes in the flow of blood with respect to respiration?
Whenever we inspire deeply, so the SPP it falls.
You read and tell me the changes of Doppler with respect to respiration. Imagine I'm doing Doppler, but I'm not getting, the patient is telling he's having chest pain, but on Doppler nothing is visible significantly, still I'm not getting proper Doppler findings. Then is there anything I will do?
And collateral CT angiography, I guess we should proceed with.
The same thing which you have done, plantar flexion and dorsiflexion. You have done the manual, right? You told the plantar flexion and dorsiflexion. You'll do the plantar flexion, and so you'll do the plantar flexion and you'll do the dorsiflexion, and again you see the Doppler.
And based on this Doppler also, no, Sakshi, which area you cannot do examination by using this Doppler or which segment of vessels?
Uh, so I like the aortic, I mean the aortoiliac
So your
region.
proximal blood supply, no, aorta iliac segment, you will be not able to see these vessels. And also based on this Doppler, no, you can calculate the ABP also.
Yes, ma'am.
And also very much important is that, as Madam told, by doing this manual also, post exercise ABP also you can calculate.
Yes, sir.
If at all the patient is complaining, telling all the history suggestive of PVD, but the Doppler is normal, then you will do the post exercise ABP. It is very important. If there is any change greater than 0.2 or
Yes,
any
ma'am.
decrease less than 0.7 ABPI, then you call it as a significant thing.
20% full.
Yeah, yeah, 20%.
Yes, ma'am.
Yeah,
20%
yeah.
full. Yes.
Then how do you proceed in this patient?
Ma'am, first of all, like
Any
I
Doppler
would
USG is there? You have any photo of the Doppler?
ma'am, like I took the photo, but I didn't attach it here in
Any
this
there,
PDF.
can you read the report?
Yes, ma'am.
Roughly, in which vessels the flow is there, not the just tell me that.
Moderate atherosclerotic plaques and up to 50 to 70% stenosis of proximal superficial femoral artery.
Okay.
Then poor intermittent collateral flow in right popliteal artery.
Okay.
Moderate atherosclerotic calcific plaques were noted in anterior, right anterior tibial, posterior tibial arteries.
Okay.
Um, Thrombosis in posterior tibial artery.
Okay. Any mention on dorsalis pedis?
Dorsalis pedis, yeah, like thrombosis and absent flow in the dorsalis pedis artery.
Okay. Okay, fine. Thrombosis in dorsalis pedis and 60 to 70% thrombus in superficial femoral, remaining only moderate thrombosis. Fine. Then how do you proceed with this patient?
I guess surgical intervention would be
No,
required.
no, 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 no. How do you proceed?
Lifestyle modifications first, I would be advising.
Sakshi, rest pain. The patient is having rest pain. Now, what lifestyle modification you will give with this patient? He can't move. You will ask this patient to exercise.
No,
Normally,
ma'am.
when how do you tell the patient to exercise till you cross your distance, no claudication distance? What claudication distance does this patient have?
Ma'am, he's having rest pain right now, so
Yeah. Then what lifestyle modifications? How do you proceed? You do any CT angio or any sort of thing?
yes, ma'am, CT angiography would be required.
Why do you do CT in this patient?
Ma'am, to look at what a site is the block, what is the nature of occlusion, what is the
Yeah.
extent of
Yeah,
occlusion.
extent of the block, the level of the block. If at all the vessel previous to the block, how is it? The vessel distal to the block, how is it? You have told only
Raman
moderate
and Rama.
atherosclerosis in popliteal artery, but you don't know how the entire vessel is, right?
Yes,
Whether the
ma'am.
complete vessel is involved or the segment is involved. Because in the Doppler, na, they'll tell about entire vessel. They'll not tell every section of the vessel, right?
Yes, ma'am.
Yeah, and they didn't they will never mention about the branching in the Doppler report.
Mhm.
So in order to do any intervention, you need to know how the proximal supplies and how the distal cutoff is also, right?
Yes, ma'am.
So you will do with CT angio. Why not MR angio?
Mm.
Why not DSA? Do you know what is DSA?
Digital subtraction
Yeah.
angiogram.
Yeah. Why not MR angio?
Mostly MR-NGO we do in those cases where there's a contraindication for CT-NGO.
No, you are this patient, you are a diabetic patient. No, you are this is the ideal patient to do MR angiography
Mm.
because your diabetes, no, it will predominantly involving your crural vessels, no. So your CT angiography will
Mm.
not pick up your how the blood supply to your foot vessels, and especially in diabetic patient, it will be having a severe atherosclerosis, no. So CT will not give exact reports because CT is showing multiple
Right?
artifacts. So that's why in
No,
this
no. And what more thing? One more thing. Calcification. Diabetes and calcification grow in hand in hand, right?
Yes, ma'am.
Yeah. And and always remember, Sakshi, in the distal, the more distal you go, the significance of CT decreases. The CT is very
Mm.
good investigation to see abdominal aorta, to see iliacs and all sort of things. The peripheral you go, the branching starts, right? The much smaller
Mhm.
vessels. So the chance of
Yes,
CT
ma'am.
getting detected is very less. So distal subtraction angiography is a very good thing. If not, it is an MRI angiography.
Okay, ma'am.
Yeah.
So for this patient, no, Sakshi. So there is a recent
Mm.
classification is there, that is Wi-Fi classification. Wound ischemia, foot infection classification is there. So based on this, how is the status of wound? How much is the ischemia based on ABPI level, based on transcutaneous pulse oximetry and ankle systolic pressure, and also,
Mhm.
and how is the foot infection? So based on that, no, you will
Okay.
classify the patient and you will decide the what is the level of this patient. How the TNF staging is there, no, this Wi-Fi staging is there. So based on that, you will classify this patient, and after classification of this patient, you will calculate the like how much this patient is having perioperative mortality rate. If the patient is having
Mm.
perioperative mortality rate more than 5%, no, you will go with predominantly only
Mm.
your intervention procedures. If the patient is having perioperative mortality less than 5% and is having good life
Mm.
expectancy, then you can go with bypass or surgery, or else your percutaneous intervention or angioplasty is enough in this patient.
It's simple. If you are patient, if you are taking the patient to OT, the patient should
Mm.
have some sort of chance. Now, if the patient is having very high risk, why doing all this sort of procedures? Just go with an amputation, right?
Yes, ma'am.
Yeah.
So if you are, because your
So
bypass procedure, no, these are very much time consuming. You need to give abdominal surgeries, long bypass procedures and all. So patient will not tolerate that much stress in this age. So you will be going in the less invasive procedures such as angioplasty or stenting or thrombolysis as they have done previously in this patient.
Yes, ma'am.
So now what you
so
want to do, which management you want to go ahead now with your, more likely your some sort of intervention, that is your angioplasty or stenting only or thrombolysis.
Mm.
in digital vessels at this level, you are telling that roughly the block is at superficial femoral, right, Sakshi?
Mm. Mm.
Is there whether stunting is good or whether which one is good option?
Ma'am, bypass
No,
maybe.
not bypass.
Bypass.
Because patient is very much old age. No bypass. You can do bypass if the patient is patient was having lesser age and lesser severe comorbidities.
The life expectancy after doing bypass, now how much years does the patient have? The patient is already in his 70s, right?
76
Yes,
years.
ma'am. It is.
Yeah, for 10
Mm.
years. Maybe he'll live till his 90, another 14 years. Do you think you have to do itana morbid procedure?
No, ma'am.
Yeah. So, is there any significance of doing lumbar sympathectomy in this patient?
No, ma'am. And rest. Yes, ma'am. And rest pain can be
Hmm?
done.
As a last modality, right? But
Yes, ma'am.
as a therapeutic management, is there any indication of doing lumbar sympathectomy? Why do you do
Mm,
lumbar sympathectomy?
because a sympathetic system is responsible for vasoconstriction. So,
Yes. So the patient has vasodilatation. So there will be wound healing. Any small ulcers will get healed. So there won't be any problem, right?
mm, yes, ma'am.
In this patient, if everything fails and the patient is having so much excruciating pain, then only lumbar sympathectomy will be an option, or
Yes,
else
ma'am.
no. Yeah,
After doing your intervention.
yeah.
So
If the intervention,
as this is superficial femoral artery, as you go more proximally, so your stenting is better rather than doing simple angioplasty.
Okay, sir.
Okay, so you have to do.
Sakshi, any medication you start?
Ma'am, aspirin.
Okay.
Statins can also be given.
Yes. What more?
Ma'am, vasodilators like cilostazol can be given.
Okay. How does silastazole works?
Ma'am, it is a phosphodiesterase 3 inhibitor, so it
Yes.
will do
Yes.
vasodilation.
Yes. What more things?
Ma'am, I guess levocarnitin has also some
Okay.
role in it.
L-carnitine, fine, but not utna significant. Yes. What more?
Maybe pentoxifylline is also a vasodilator.
Yeah. Pentoxifylline is a specific vasodilator, or what is its specific mechanism?
Ma'am, it alters the shape of RBC, so like it would be easier for it to pass even when there
So
is
it
no.
it changes the viscosity of the blood. It decreases the viscosity so that blood can pass easily. Yeah.
Hmm.
What? Or what one more drug which is significant in PVD?
Mm, clopidogrel aspirin stat.
Yeah, yeah. Any Trentol, Complimena. What is Trentol?
Xanthiol nicotinate.
Yeah. How does it acts?
Ma'am, I don't know the exact mechanism, but it's
Trentol?
also vasodilator.
Trentol is nothing
Xanthiol,
but Trentol is nothing but your
pentoxifylline.
pentoxifylline.
Pentoxifylline, yes, ma'am.
What is Complimena then?
Nicotine.
Xanthiol nicotinate.
How does it act?
Ma'am, it is a vasodilator, but I don't know the mechanism.
Okay, okay, good. Any questions, Ismail?
No, no, that is enough. This is how you know. Basically, whenever your patient is old age, no, so simple angioplasty stenting management. If patient is younger age, you can go with the bypass procedure such as your aortoileal bypass, aortobiofemoral bypass. If the aorta is not good, then you can go with the axillobiofemoral bypass also.
But unlikely the chances of what do you call but it gets occluded very easily and the complications are very much more.
Yeah.
So
Mhm.
So there are multiple criteria where to be stent inserted, where to be drug eluting stent should be inserted. So these are all the
what different sort of stunts, what the materials to be used, whether it's a dacron, whether it's an
PTFE
nitinol,
stent.
yeah,
Mm,
or whether it's a ptfe.
so
It's
what
very
are the
important.
how to follow up this patient in the post-operative? What are the complication of this stent? What are the complication of graft? And what are the complication of this bypass surgeries also? So some of these are very much important questions. So Sakshi, go
mm.
and make notes of these questions, okay? And
Yes, sir.
overall summary, no, your case presentation was good, but never miss the ulcer examination in surgery, okay? Because ulcer
Yes,
is
sir.
very much important.
Yes, sir.
They won't expect great things, Sakshi. They expect basic things, even from a postgraduate. Very basic things. How are you mentioning the ulcer?
And
Basic things only they examine.
peripheral pulsation examination and all. So if you don't know
All
management
the
also
bony
fine. Sometimes
prominence.
they think okay, but they are just doing peripheral examination, management of examination of ulcer is very much important.
Because the management of PVD is not UG level, not even PG level. It's a vascular surgeon who actually tackles this
Mm.
atherosclerosis, all sort of things. So what they expect if the patient comes acutely, how do you manage this case? That's what they expect you. Whether
Yes,
you are
ma'am.
doing everything what is needed. Yeah,
Okay, so
It's a very good presentation, Sakshi.
Thank you, ma'am.
Yes.
okay. Thank you. It was good presentation, Sakshi.
Thank you so much, sir.
Thank you. Chalo, bye bye.
Yes, sir.